Let me just ask the panel to talk a little bit more about mechanism. Now, we've heard about the clinical response to the one randomized trial that we have in the literature, and a very nice summary of the phase 1 and 2 data leading up to that trial. You mentioned 3 mechanisms: enhanced angiogenesis, promotion of apoptosis, and inhibition of repair mechanisms. One of the clinical dogmas that we hear about is this concept of accelerated repopulation of tumor cells, and that this occurs as we get into radiation. Can you comment, and I think we can go around the panel, in terms of how you think this particular EGFR inhibitor may affect that? And we can start perhaps with Dr. Belka.
Yeah, it's just actually one of the first points I just noted here. The question is, couldn't we interpret the data as that the C225 antibody really just blocks accelerated or even simple repopulation as the best interpretation of the data we have? And then we would come into the next question in how far it is really still useful if we are in a combined modality setting to use hyperfractionated radiation therapy in combination with the antibody. How would you see that?
I can tell you what the question is.
I mean, my interpretation is the data you showed, the clinical data in combination with the preclinical data, is that the antibody exerts at least part of its activity in a patient by blocking repopulation.
Yes.
And then the second question would be, if that really holds true, do we need hyperfractionation in a setting where the antibody is present?
Probably is one of the mechanisms. There is also another mechanism. For example, has been well shown that in combining cetuximab and radiation or erlotinib and radiation induces apoptosis. So there is another mechanism also, but I think that you can. In this kind of setting, probably the use of accelerated radiotherapy with cetuximab will benefit, but it's something that in the clinical trial we are at the moment evaluating survival according to the radiation regimes, and it's a subset analysis, and what we know is that patients treated with hyperfractionation or with accelerated radiotherapy and cetuximab do better. But is something that I think that needs to be more studied before arriving to solid conclusions. Mm-hmm.
Professor Budal?
I think it might be conceivable, of course, that the antibody blocks the receptor, of course, and like this decreases the accelerated repopulation. But on the other hand, we know from many schedules where chemoradiation was involved that chemo already itself blocks repopulation. So this is the second question I would like to address. Is it really necessary to introduce Erbitux or whatever, antibody, into a chemoradiation schedule, because there this issue of accelerated repopulation plays most probably not that role. On the other hand, we can conclude that it is perhaps the best way to use it with pure radiation. But then, most probably, it's not necessary to use accelerated or hyperfractionated treatment regimens. But this is speculation.
Yes. It's a difficult question, no? Because from the randomized phase trial with chemotherapy, cisplatin versus cisplatin plus cetuximab, we know that combined cetuximab and cisplatin increase response, and this is a small group of patients, 60 patients only in each arm. There were no differences in survival, but would be probably due to the fact that the study was really small. So it has a sense to combine cetuximab and cisplatin. And again, it has a sense to combine cetuximab and radiation. So the difficult question, and for me it's a pity that these three arms will not be realized. It's really a pity because maybe it will help us a lot to select better the patients. So I think that we couldn't say more than that till the next future trials will give us more results. But I think probably for a very bad prognostic population as very large tumors, in that tumors probably I think that there is a lot of sense to combine the three modalities. But maybe in an intermediate group, maybe the 2 to 1 to 3, T3 and 1. In that intermediate group, maybe it wouldn't necessary to use the three modalities. But this is also speculation.
Professor Wen, would you like to comment?
In chemoradiation, there are some subsites, for example, the hypopharyngeal cancer, which do not profit as much like the tonsillar carcinoma from chemoradiation. Can we expect a similar effect on cetuximab?
I don't know if there has been an analysis by subsites. So I don't know the data. I'm sorry. There is an analysis for laryngeal preservation that this morning Jan has presented, and there is a small, not statistically significant benefit, but benefit maybe also because of the number of patients. But for hypopharynx, the analysis has not been done, so I'm sorry, I can't tell you.
So I think this discussion highlights actually some of the limitations of the randomized Bonner study, the fact that the population is actually heterogeneous with 3 different primary sites, although the dominant site was oropharynx, and also the fact that there were 3 different radiation schedules. And certainly the study is not powered adequately to look at subset analyses. So although we may see something on subset analyses, it's not going to be definitive data.
Yes.
So one could certainly propose that going forward we may have to take a step back and look at standard fractionation radiation with cetuximab and do a site-specific trials, and also adding in chemotherapy, but with more of with some scientific rationale behind the steps that we're taking. I think all of us may be concerned that with the cetuximab data, there's an eagerness for lots of studies to be initiated that may not be thoughtful progression stepwise, answering specific questions. Now, are there any comments from the audience? Would anyone, I see Dr. Posner standing there. Do you have any comment? I think the other point I'd like to make, when we get later this afternoon, we have a quality of life panel on related to radiation, and certainly we do not have late effects data from this study yet. If we add in radiation, accelerated fractionation or hyperfractionation, we may see more late fibrosis and effects on function. So I do think we have to be very cautious as we move forward. Yes, Dr. Posner.
Second abstract in ASCO 2005 looking at hypopharynx and larynx. And he showed some improvement in laryngectomy-free survival, but no effect on survival in the larynx and hypopharynx patients, suggesting that almost all of the effect on survival was in the highly good prognosis oropharyngeal population. So this has to be compared with what we see with cisplatin, for example, in unresectable populations, with the cisplatin and with the carboplatin 5-FU data in oropharynx, published by Calais and followed up by Denise in the Journal of Clinical Oncology, where the 2 and 3 year survivals were 50 versus 20%. Which is an approximate 60% improvement in survival, whereas the survival in this trial is really an absolute value of about 13% at 3 years and represents about a 25% increase in survival. So there's, without really being able to directly compare the studies, it really seems that the cetuximab effect is real. It seems to be predominantly in oropharynx based on extrapolations from the abstracts. And it's not quite as robust as the data we see with chemo radiotherapy with both carboplatin 5-FU or cisplatin alone. And I'm referring to the intergroup trial in which there was about a 70% improvement, relative improvement, and an absolute 14% improvement in survival with bolus cisplatin versus standard care radiation, which was not hyperfractionated. So, and hyperfractionated radiation has only a borderline improvement on survival. So I think there's clearly a survival advantage. Whether this outweighs the survival advantage of chemo with cisplatin-based therapy versus cetuximab is unclear. And the role of fractionation, as you pointed out, is quite unclear, since we have 3 different kinds of fractionation in this study. And I think it may be that when this is analyzed, one could ask, did the cetuximab only help those patients who had single fractionated radiation, as you suggested, or did it help the hyperfractionated population? And that analysis was never provided in any of the abstracts to date in that study. So I think those are all questions that we need to hear before we go further with other trials.
Yes, but the problem with the subanalysis is what you said, that it is not well powered. But I think that from the data I've seen that combining cetuximab with accelerated radiotherapy or with hyperfractionation radiotherapy improve outcome, improve results. But again, it's the same problem with the larynx and hypopharynx. You're only studying subgroup of analysis, and it's difficult to draw clear conclusions. I think that if you are planning to use radiation with cetuximab, it has a lot of sense of using this strategy using radiotherapy in a hyperfractionation or in accelerated scheme. But if you are going to use the 3 strategies also with chemotherapy, then the best is to use conventional fractionation with radiation and chemotherapy. But is again, we know, for example, for the phase 2 trial presented by Pfister, that they have a lot of toxicity using high accelerated radiotherapy plus cetuximab and chemotherapy.
Let me ask the panelists, assuming that we get approval both in Europe and the U.S. In the coming months of cetuximab, how would each of you integrate that into your standard of care practice, or would you? And so let's start with Dr. Belka, please.
I mean, from an academic standpoint, this trial is a brilliant one because it, for the first time, shows that a molecular targeted agent in combination with radiation does something positive to our patients. However, the question we are just addressing makes it quite complicated to integrate that into the day care of our patients. So I would not see, for a today perspective or tomorrow perspective, where to integrate cetuximab in the standard care. So for most of our head and neck, it would be still chemoradial with the question of whether we should add cetuximab unsolved.
Okay. Yes.
In Europe, I think we would not have be able to perform that study because the advanced cancers, at least the T3 with nodal metastasis, have to undergo chemoradiation. And I think it would be a step back to omit chemotherapy to be able to add cetuximab. On the other hand, in the post-operative setting, we give radiotherapy alone, at least in patients without risk factors, but in this setting the cetuximab is not proven so far. So I think it is difficult to integrate cetuximab at the moment. Mm-hmm. Probably there is a place for patients with recurrent disease.
Dr. Budak?
I also would only advocate to use cetuximab on a basis of a prospective clinical randomized trial here in this setting, because we have to compare it with the best modality we have at the moment, which is chemoradiation, and then we would add one arm for pure chemoradiation, another arm with cetuximab. Then I would, of course, in this setting I would use it, but not as a general recommendation, because this is only one trial. And we all know that there are so many trials which have been positive, and later on trials did not support this on the whole situation. So I would be a little bit critical also.
Okay, so we have a very cautious panel.
Can I have a comment? Because I think that there is in this situation that you have planned, there is some patients that could benefit from using both, and those patients who are not suitable for chemotherapy. For example, if I had the drug approval and I have a patient with 75-year-old or 85-year-old not suitable for chemotherapy, in this situation I will recommend the use of cetuximab plus radiation.
Okay. Yes?
It's important point of view, because definitely cetuximab is prolonging life in combination with radiotherapy, so this is a very strong argument. So if a patient has a contraindication for example, cisplatinum due to renal failure, or if he has a DPT mutation and has to expect extreme degrees of toxicity by receiving 5FU therapy, so apparently I cannot see how you would refuse in treating these patients with a combination with cetuximab.
Mm-hmm. You're right. Yeah.
Dr. Forastiere?
Well, I agree with that, and I would like to ask the panel, how do they interpret the update of the MAC meta-analysis on chemoradiation, where it was clearly indicated that patients over 60 or 65 did not benefit from chemoradiation over radiation alone? So maybe that they could put the usefulness of an agent like this in the context of the data of that meta-analysis.
Yes.
But it would be interesting whether cetuximab acts in patients over 60.
Of course. I don't know the data.
No.
Yes.
Perhaps
please.
I can answer you this question later on, because I will tell you some of the data of this meta-analysis later on behalf of Jean-Pierre Pignon and Jean Buhis. And you are right. I think this is, of course, a situation which have to be proven, that most probably I think it will be successful in this group of patients, the elderly one, because, and this is what I wanted to also very much make a strong comment on that, we have here an example in this study of a real improvement of the therapeutic ratio, because we have better outcome without increasing toxicity. And this is the typical example what we are striving at in every study, but we don't have the luck to see it always, or only very seldom really, because usually with chemoradiation we have increased toxicities, sometimes even late morbidities, and here we see just an improvement quite considerably, and even at the end point of overall survival without increasing toxicity. And this is the most strong point for this study, I think.
Yes.
While I agree that the acute mucositis as measured in this study does not seem to be increased, there is no long-term morbidity discussion anywhere in the abstracts. We don't know how many patients remained stomach tube dependent, had persistent fibrosis, whether they were hyperfractionated radiation cases or not. So we don't have any of that information. And if you look at the platinum data, it's really very marginally larger than just the hyperfractionated radiation alone. So I think hyperfractionated radiation, either accelerated concomitant boost or twice daily, does lead to significant scarring, fibrosis, and long-term side effects, which were not captured in any of the abstracts presented or the data I have seen on C225 in this study. And I think that's a major shortcoming. We need to know how many people were stomach tube dependent at the end of therapy at 2 years among survivors so that we can really gauge the long-term morbidity. And that's an objective measure, I think.
Yeah. Mm-hmm.
Other comments from the audience? So if I'm interpreting the panel correctly, I think that the panel is saying that we need more clinical trial data, that the appropriate radiation fractionation schedule in terms of theoretical modeling needs to be evaluated further. We need data on late toxicity. And then at the moment, the patient population where this may be used, and there seems to be some agreement, would be a patient where chemoradiotherapy was contraindicated. Okay.